Much for Great. This thing is recorded like as every time, and we're going to have it in the thing for people who missed it. Appreciate everybody coming in, and I'm really appreciate of course Tarak, CME chair, for putting leading the thing, but this time especially Atul Prakash, who's an electrophysiologist, cardiologist by himself, and he has put an excellent panel together. The topic here is the atrial fibrillation. How do you manage it without medication? Which I was very interested, because, as I was just telling before you guys came on, is that we have a lot of our cases canceled because the patient is on blood thinners and due to atrial fibrillation. And so this will be a very welcome change if this catches on. And thank you so much for putting this excellent panel together. Let me tell you, we are going to, from now on, from next month onwards, our CMEs will be set third Sunday of each month.
Sunday, yes.
Third Sunday of each month. The timing will vary a little bit, maybe, but it'll be third Thursday of each month, and we'll actually eventually get the timing also just set, so that everybody marks their calendar and knows that they are going to have to come in for that. Another thing which we want to make sure that you guys understand, AAPI membership is only $100 lifetime membership. There is no organization, even in India, they charge more than that, than AAPI charges. Lifetime membership, $100. If you guys want to get CME credits, it's just fair that you just become AAPI members. $100 for getting 50 CME credits for the whole year is something, not a great thing to ask for. So from now onwards, we are going to only give CME credits to people who are AAPI members, and we'll have some other options which we're going to talk about. But having said that, today's talk, I just specially dressed up and ordered a t-shirt just for this talk. So this t-shirt, I hope you can see this.
Oh my God.
This is totally atrial fibrillation t-shirt. Okay, the EKG t-shirt, and it shows coffee can maybe cause some atrial fibrillation issues. So I thought that this was a very appropriate t-shirt to wear for this occasion. So
very well.
Having said that, over to you guys.
Okay, Amit, I will just say that thank you, and I really like to thank Dr. Atul Prakash for arranging the CME with two eminent speakers, which he's going to introduce. Like Amit said, we're going to do this Sundays, possibly at 2 p.m. Eastern time. Next one is already being arranged on AI in medicine in different aspects we're going to discuss. And the one after that likely will be arranged by Amit with different aspects. So it's a great venue. Please join us again and again. There is some difficulties in registration, but is needed because of the required for the rule. And I know they ask you for a date and month of your birth. So that is understandable because they have to keep records also. And after the CME is over, you will get an email, you do the evaluation, and you will get CME itself in the next couple of days or so. And over to you, Dr. Prakash. Go ahead.
Thank you, Tariq, and Amit, being the president of AAPI, and Tariq being the CME chair, for facilitating this. Let me introduce the speakers who are very, very, very well known, and also great friends. Dr. Suneet Mittal is not only the director of electrophysiology of the Valley Health System, but he is the chairman of cardiology and literally of the whole system, which is quite prestigious. He actually runs the department of cardiology, and he has brought Valley to where it is, not the other way around. So apart from that, he's involved in ample research, and for years, multi-center studies. I cannot elaborate all of them, but they are tremendous for a long time, and he has great experience in atrial fibrillation treatment and management right from the inception, which I'll allude to in a sort of short time. Suneet, in case I've forgotten something, I will add it at the end. I'm sure I have. And by the way, I and Suneet met at a meeting for atrial fibrillation when we ablated with a different kind of catheter. It was on the East Coast. It was the Cardima catheter, Suneet, if you remember. He was at Cornell and I was here, and we were just doing a walk. There was no vein isolation, or it had just emerged. That's how we were ablating atrial fibrillation. Dr. Mehta, also a sort of great friend. He's also my go-to. I spoke to him this morning when I was doing a case. He was and is, director of electrophysiology at the Mount Sinai Health System, and now the director of electrophysiology at St. Luke's, which is the West Campus of Mount Sinai. I used to also go there, and I will honestly admit, if I didn't do something, I used to go to St. Luke's and pick it up from Dr. Mehta and bring it back to New Jersey. But the worst thing about Dr. Mehta is that he has trained all these EP fellows all over the state and the country. And to my disdain, there are some who become, competition right in my neck of the woods and in, Sunit's neck of the woods. But having said that, it is a it is a pleasure to have new electrophysiologists all the way. So he has trained, many other common denominators, was in the UK like me. So without much ado, I'll turn to atrial fibrillation. I I like linking, sort of physiology and philosophy in the sense that um, atrial fibrillation, like all diseases, it actually self-perpetuates. That means the more atrial fibrillation you have, the more difficult it is to cure. I'm sure Sunit and Dr. Mehta will remember in the late 90s, we used to be asked to ablate people who had failed a cardioversion. That is like stage 4 cancer, implying that the electrical disease, once it is so late, it's like aging. I mean, how do you expect to reverse it? Um, Hence, the efficacy of atrial fibrillation was not as great as it has become now. I won't steal the show, which Dr. Mittal and Dr. Mehta will sort of allude to. And the premise of the talk is, can we treat the disease without drugs? The answer is yes. We are we are coming to those crossroads, whether in an attempt to cure a disease which is because of aging. Don't forget atrial fibrillation. People ask me, why do I have atrial fibrillation? I said, well, and you see the color of my hair? It's white. It's a part of aging. It is scarring which occurs in our body. And the same scarring occurs in the atrium. Hence, to cure it is a big venture. But if if ablation is adopted early, that means if you take the analogy of cancer, how do you expect to cure when you have stage 4 cancer? But yes, stage 1 disease, when you have atrial fibrillation, when you ablate early, you do achieve cure, as we see in here, many of our patients who become AF free. So that is one part which Dr. Mittal will allude to. The other issue we face is, as Amit mentioned, and the use of anticoagulation and blood thinners. Like aging, as we get over 65, 70, we will have some bleeding. We will become unsteady on our feet. We will have falls. Being on anticoagulation, yes, which minimizes the stroke risk of ischemic infarcts. There are risks, there are perils of being on anticoagulation. Hence, what better state to be in to, one, firstly, if you can achieve it, and to cure atrial fibrillation, so that if there's no atrial fibrillation, there's no need for anticoagulation. But in the instances when we do not cure atrial fibrillation, at least we should be in a position so that we can do maneuvers where we don't need anticoagulation or blood thinners thereafter. So with this preamble, I will turn the floor to Sunit, who will talk on the first part of the of this preamble. How can we cure atrial fibrillation with ablation, which has come a long way since the late 90s when we all started ablating till now. Sunit, over to you.
Thank you very much, Atul, for that very kind introduction. I just want to confirm that you can see my slides, yes?
Yes.
Okay, very good. So let's talk a little bit about why this is an important topic, and it certainly is a very exciting time to be an electrophysiologist. So the first thing I want to really share with you is I want you to understand how explosive the growth of ablation, and in particular atrial fibrillation ablation, has been in the United States. So in 2021, there were approximately 500,000 procedures being done. And you can see that they were roughly half for AFib and the others for the traditional things like SVT and VT. But over the last couple of years, there has been an explosive growth in the number of procedures being done, such that there's almost a 20% year-to-year growth rate in in overall ablation, being driven by an almost 25% growth rate in ablation of atrial fibrillation. And what I really would like to talk to you about today are the drivers for why that is happening. And I'm going to put it in the context of the 2023 ACC AHA HRS guidelines for the diagnosis and management of atrial fibrillation. Now, these guidelines very nicely spell out 4 Class 2A recommendations for rhythm control in patients with atrial fibrillation. Specifically, they state that in patients with symptomatic AFib, rhythm control can be useful to improve symptoms. In patients with a recent diagnosis of AFib, rhythm control can be useful to reduce hospitalization, stroke, and mortality. In patients with AFib and heart failure, rhythm control can be useful for improving symptoms and improving outcomes, such as mortality and hospitalizations for heart failure and ischemia. And importantly, a new concept that's emerged is that in patients with AFib, rhythm control strategies can be useful to reduce the likelihood of AFib progression. So let's think about this in the context of some clinical cases. So the first case I'd like to present to you is a 50-year-old male who presented to our emergency room with a several-week complaint of palpitations. ECG showed atrial fibrillation with rapid ventricular response. He was admitted to the hospital, as often happens. After about 8 hours, he spontaneously converted to sinus rhythm. Subsequent laboratory data, chest X-ray, echocardiogram were all within normal limits. And an ambulatory external ECG monitor was obtained and is shown here, where the patient had recurrent paroxysms of atrial fibrillation. Again, when we turn to the guidelines state as a class of recommendation level 1 that in selected patients, like the one I've described here, generally younger with few comorbidities, with symptomatic paroxysmal AFib, and whom rhythm control is desired, catheter ablation is useful as first-line therapy to improve symptoms and to reduce progression to persistent atrial fibrillation. Now, prior to pulse field ablation, which I'll describe in a second, in the era of thermal ablation, we had already done randomized clinical trials using the cryoballoon to evaluate patients like the one I've described previously, in which they were randomized to catheter ablation or pulmonary vein isolation using the cryoballoon versus antiarrhythmic drug therapy. You see the Kaplan-Meier curve on the right, that a significant greater likelihood of treatment success in patients randomized to catheter ablation. But we've also known that catheter ablation using thermal energy sources, whether it's radio frequency or heating or cryoablation or freezing, is associated with the inadvertent risk of collateral damage. And some of the areas that we had worried about as electrophysiologists were pulmonary vein stenosis, phrenic nerve injury, or inadvertent damage to the esophagus. And what has really been the game changer has been the advent of pulse field ablation. Pulse field ablation is non-thermal. It induces apoptosis through irreversible electroporation. And what you see is the process in which it occurs, in that a precise and momentary high voltage electrical field is created by the catheter. The field causes pores to form in myocardial cells, a process called irreversible electroporation, and this then leads to cell death. Now, the extent of electroporation and induced cell death is dependent on the strength and duration of the applied electrical field. If you deliver too much, you will actually get the same thermal damage and all the collateral injury as is inherent to thermal ablation. If you don't deliver enough, you will get reversible electroporation, and the effect and the arrhythmias will come back. For those who are not familiar with how this works, here's one such example of how PFA is delivered through one company's proprietary PFA system. Here you see that a transeptal puncture has been performed, and through the transeptal puncture, basically a catheter is introduced into the left atrium. A guide wire is advanced into one of the pulmonary veins. A catheter is basically then configured in various configurations and basically placed against the pulmonary vein LA junction, and basically these high voltage electrical pulses are delivered to basically electrically disconnect the left atrium from the pulmonary veins. And this process can then be repeated in multiple veins. And importantly, we believe that the process is cardioselective and thereby sparing nerve cells, the esophageal smooth muscle, and the vascular smooth muscle, reducing the complication rates. Now, we know that the data for this exists. So in this randomized study by Vivek Reddy at Mount Sinai called the ADVENT study, pulse field ablation was compared to conventional thermal ablation for paroxysmal atrial fibrillation. And he looked at three important endpoints: efficacy, safety, and procedure time. And what he found was the efficacy of the two approaches was similar. The safety profile was much better for pulse field ablation. And when you look at procedure times, you see that there's a marked reduction in procedure times. And what I think it's important to note is that what was once a 6-hour procedure, and Dave and Atul and those who have done this for a long period of time well remember the days of the 6-hour procedure, has essentially been reduced to a 90-minute procedure, which now facilitates the ability to discharge almost every patient the very same day. We also have more recent data where pulse field ablation was randomized to cryoablation for paroxysmal atrial fibrillation. And in this study, you can see a significant improvement in outcomes or efficacy with pulse field ablation as opposed to cryoballoon or thermal ablation. And in the United States, the vast majority of these procedures now incorporate pulse field ablation. Now, let me share with you a different type of patient. A 63-year-old male with hyperlipidemia presented with decreased exercise tolerance and was found to have atrial fibrillation. A 1-week ambulatory external ECG monitor showed the presence of persistent atrial fibrillation with poor ventricular rate control. A echocardiogram suggested the presence of a tachycardia-induced cardiomyopathy. Electrical cardioversion was performed. However, the patient had an early recurrence of atrial fibrillation. Again, when we turn ourselves to the guidelines state that in patients with symptomatic AFib, in whom antiarrhythmic drug therapies have been ineffective, contraindicated, not tolerated, or not preferred, and continued rhythm control is desired, catheter ablation is useful as first-line therapy to improve symptoms. Now, if you are managed in our laboratory, we have long recognized, as per the guidelines, that often you need to do more ablation in these patients than is true of patients with paroxysmal atrial fibrillation. So many like us felt that if you pre-treated these patients with antiarrhythmic drugs like dofetilide, you could potentially simplify the procedure for them long term. But now we know that with pulse field ablation, this may not even be necessary. We're awaiting the results of this study called the Avant-Garde study, in which patients exactly like the one I've described to you were randomized in a 2-to-1 fashion to pulse field ablation versus receiving antiarrhythmic drug. The results are going to look at the primary safety and effectiveness data. But I can tell you that the data are pretty clear worldwide, and especially in the United States, that there has been a marked decrease in the amount of antiarrhythmic drugs being used, drugs like sotalol, dofetilide, amiodarone, in preference for moving forward with catheter ablation. And I think this trend will continue over the next several years. Now, a third type of presentation is a patient like this. 79-year-old female with hypertension, history of left-sided breast cancer, and history of paroxysmal atrial fibrillation for the past 5 years. after having failed treatment with 2 antiarrhythmic drugs, she developed a tachycardia-induced cardiomyopathy. Thus, 4 years ago, she underwent a cryoballoon-based pulmonary vein isolation, and within 3 months, her ejection fraction had normalized. However, recently she presented with recurrent symptoms. ECG monitoring showed a 7% burden of AFib, longest episodes lasting 10 hours and 14 minutes. Again, when we turn to the guidelines state that in patients with recurrent symptomatic atrial fibrillation after catheter ablation, repeat ablation or antiarrhythmic drug therapy is useful to improve symptoms and freedom from atrial fibrillation. Now, here again, we've had real advances in technology, pulse field systems that, as a single catheter, can map and provide three-dimensional electroanatomic mapping system, can in the same catheter deliver radio frequency or pulse field energy. And this has really, again, been an important game changer that allows us to address these patients effectively through repeat catheter ablation. Then the last group of patients are those that relate to oral anticoagulation. And I'm not going to steal all of Dave's thunder, but I'll just present you 2 types of patients that we're seeing commonly in clinical practice. So here's a 68-year-old male with hypertension, diabetes, prior coronary disease, and PCI, who underwent pulmonary vein isolation 4 months ago for management of highly symptomatic PAF. And now he comes to your office. He feels good. There's been no further atrial fibrillation. And like many patients, he wants off oral anticoagulation. What do we tell a patient? Well, when we look at the guidelines state that in patients who've undergone AF ablation, the decision should be based on their CHADS VAS score, for example, and a patient like this would be relegated to lifelong oral anticoagulation irrespective of the putative or perception from the patient that he is AFib-free. We'll talk about that in a second. Here's another patient, 81-year-old male with hypertension who recently presented with intractable coughing. ECG showed AFib with ventricular rate control that was reasonable. However, his biomarkers were elevated, consistent with a diagnosis of heart failure with preserved EF. He was started on oral anticoagulation, but had a unexplained, likely GI bleed. And here's a patient who's being referred for left atrial appendage closure, but has underlying atrial fibrillation in the setting of heart failure. In both of these conditions, there are now data that left atrial appendage closure may be of value. This data comes from the OPTION study, which I'm sure Dave will discuss. Large number of patients randomized to ablation with a Watchman device versus ongoing oral anticoagulation with endpoints of stroke, mortality, systemic embolism, as well as a variety of safety endpoints. And when we look at this study, the mean age was 70, a third were female, high CHADS VAS score, 10% had prior TIA and stroke, 40% had persistent AFib. About 40% of the patients, the ablation and the Watchman were done in the same procedure. In about 60% of the patients, they had ablation followed by the Watchman device. And what's really important by this study is that when you look at the efficacy rate, stroke, mortality, and embolism, exactly the same, but a substantial reduction in the likelihood of non-procedural bleeding. So not surprisingly, if you can get these patients off the blood thinner, they don't bleed, but they're still protected against the other complications we worry about. And it didn't really matter whether you did the procedure sequentially or concomitantly. So I hope I've been able to convince you that this is the new dawn of the management of atrial fibrillation. Really, we've come a long way from cardioversion, antiarrhythmic drugs, to a procedure-based approach that allows us to manage these patients effectively very quickly. And I look forward to the discussion that follows. So Atul, thank you very much, and I'll turn it back to you.
Thank you, Suneet. Great talk as always. So I'll have some questions for actually both of you and my own thoughts, because you both do the same thing. And the first is, at what point do you stop antiarrhythmic drugs, if at all, and in what group of patients, what I do is on the paroxysmal, on your case one, yes, I don't have them on antiarrhythmic drugs, but certainly on the persistent, I do keep them on for about 3 months for, reverse remodeling, and then stop antiarrhythmic drugs until and unless they get a recurrence, and then make a decision. So that's the first question, and that's how I would do it. And the second is very intriguing, which will be in, Dr. Mehta's talk, is what patients do you really think should have, the concomitant ablation and the LA closure device at the same time? This is one aspect I am still sort of struggling as to which patients I would like to do both. So what are your thoughts on both of these issues, drugs and the concomitant, and the same questions to Dr. Mehta even before he starts?
Atul, I'll say that for the first one, my approach is relatively similar to you in that if a patient is on drugs and has paroxysmal AFib, I certainly don't continue them post-ablation. I would stop them immediately. Often I'll stop it in advance of the procedure just to make sure they're not masking any intracardiac signals for me. For the persistent patients, I typically see my patients in follow-up at a month after ablation. We're learning with pulse field ablation that the blanking period is much less than we used to think before. So if they're doing well at that point, then I will start weaning them off antiarrhythmic drugs so that by the 3-month visit, I have a good idea whether the ablation is working or not working. With respect to the second question, I wonder if we should just table that till Dave's talk
Yes,
and then have a more meaningful discussion about that, but I'll let Dave weigh in on both.
So, second question
Hi.
on, Devin bhai, please, over to you.
So
Yes.
I think I'll answer the first question. There's been a change in approach in terms of use of antiarrhythmic drugs, and of course, the topic you have chosen today is very appropriate. In my practice, as far as paroxysmal AFibs are concerned, I do stop antiarrhythmic drugs before ablation and don't restart them after the procedure. For persistence, it's slightly more difficult, as you and Suneet have realized that patients who have very large left atrium, they have extensive scar in the left atrium. These patients are very unlikely to do well just with an ablation. There's so much atrial disease. So I've often used the mapping data and echo data to decide whether I would continue sotalol or amiodarone for some time, at least for 6 months, till reverse atrial remodeling takes place so that they can maintain sinus rhythm long term. Sure, go ahead.
No, you were saying something. Sorry, I wasn't saying. Yeah, go on.
The second question is about the concomitant. I think the level of confidence with concomitant procedures, at least mine, is gradually increasing. And I think left atrial appendage closure is a game changer in management of these patients. The growth in this procedure has been mainly related to the safety. And I have now realized that if there's any indication I can look for a left atrial appendage closure, I am very keen to do both the procedure at the same time. And it's also very convenient for the patient, long-term management of these patients with concomitant.
Great, thank you. My thought on the concomitant is more sort of philosophical, that if we aim to cure atrial fibrillation, even though acknowledging that it is a disease of aging, and will we ever cure atrial fibrillation? So if there's no atrial fibrillation, then where's the need for anticoagulation? So that's a thought. But at the moment, I do agree with you that we are not there yet, though we are going in that direction. There is a large population of patients who actually do not get recurrence for some time. And then we cannot say what time that is. So again, a question to both of you, though the data has not borne out there was a thought, and perhaps may still be in some operators, that more is better. You know, the same theory. I mean, how much more do we ablate apart from the veins? How do you decide whether to only isolate the veins or do something further? I mean, I personally look at the scarring in the back wall, and to see for islands of scar, and then make a decision, and not really go as per the paroxysmal or the persistent. So that's what I'm using and to guide me on their first approach, whether to go after the back wall or not. Though on this forum, I have to say there's no data that ablating and the left atrial posterior wall adds any advantage to efficacy. But then, what are your thoughts on it, both of you?
So Atul, I'll just say that right now, anything I will tell you is made up because it's just, what your feeling of the day is. But the good news is we will soon have these data. So it's important to note that there are two very important randomized studies currently happening. The first is
Nice.
called SMILE AF. SMILE AF is a Brigham and Women's led study in patients with paroxysmal atrial fibrillation, where they're randomized to pulmonary vein isolation alone versus pulmonary vein isolation and posterior left atrial ablation with a loop recorder in place for objective monitoring. So in a paroxysmal patient, we will certainly know. And Avant-Garde will also help us know quite a bit because it's a persistent population in which all the patients underwent pulmonary vein isolation along with posterior wall ablation. So we will have, although that's not randomized per se to another strategy, we will know against historical controls with objective loop recorder data what the efficacy is, and importantly, whether the incremental ablation comes with any signal for harm. And as long as we're not, I think these two studies will help us answer that question.
Great point. So we'll have more answers. I was thinking, rather than more questions, if we turn to Dr. Mehta, then we can have a nice discussion at the end of both, if you all agree. Tarak, that sounds good. So anyway, over to Dr. Mehta. My disclosure is that up till 2018 or 19, was it, Devin Bhai, I was not doing LA occlusion devices. It was through his supervision that I learned how to implant a Watchman in 2018-19. So I owe my LA occlusion skill and experience started with him. I have to acknowledge that. And thereby, then I started the program at about 3 hospitals here, St. Mary's, St. Michael's. But that's why it's only befitting that he talks on stopping anticoagulation and LA closure device. Though, of course, he does ablation like you, and you do the same thing, and we all do the same thing. Devin Bhai, over to you.
Yeah, thank you, Atul. Thank you for that. You didn't have to say that, but anyhow. Can you see my slides?
Not at the moment.
So I think I knew this might happen.
No, but you were showing them before when you started.
Yeah, I think it's
Go
on
to
my...
share on the bottom. You're still a host, I think.
Let me try again. Chat, react, share.
Yeah, and then is there a share button in a green color there for you?
Can you see that now?
Yeah, screen is coming up now. Yeah.
Great.
Yes, just start your presentation and we should be there. Yeah.
Good, thank you. So it's a pleasure to be...
yeah, good. It's all
pleasure to be here, and I mean, a lot of people here. I mean, Suneet and Atul and Amit, we have met before, but I'm not a very frequent attendee of the AAPI meetings, but I think I should. Anyhow, I'm going to keep my presentation very brief, and it's about expanding role of left atrial appendage closure in stroke prevention and atrial fibrillation. If you look at the 3 important pillars of AFib management, stroke prevention is important mainly because of the mortality and morbidity associated with atrial fibrillation. It contributes to a 5 times higher incidence of strokes as compared to those patients in sinus rhythm. So it's an important part of management of these patients. And we have gone through a stage. I have an incident which I really cannot forget all my life. This is about 15, 20 years back. There was an electrophysiologist in California, Michael Lesh, and he came to give grand rounds at Mount Sinai, and he was carrying with him the first prototype of left atrial appendage closure device. And I looked at it and I said, how can this be ever implanted in a heart without surgery? I really did not respect it much and have always felt bad about not being very futuristic in my thinking. We have come a long way, and I'll just go through what are the devices available, the implantation technique, and what are the limitations, including the current indications. So the novel therapies that have come into play in terms of preventing stroke in patients with atrial fibrillation, obviously the most important has been the development of non-Coumadin drugs, factor A inhibitors and thrombin inhibitors, and these are now extensively used and virtually have replaced warfarin in management of non-valvular atrial fibrillation. I don't have to go into the details about the ease with which they can be used and the dose and the risk of bleeding. Obviously, the biggest problem with these agents is that you give them systematically, so they increase the risk of intracranial bleeds, GI bleeds, skin issues. So there came the role of left atrial appendage closure with endovascular and surgical techniques. The first devices that became available for use was the Watchman. The second one was the Amplatzer, which was subsequently modified to an Amulet device. There are at least 5 or 6 new devices that are in development. And I'm sure in the next 4 to 5 years, we will have even better options than what we are using. But the growth in this procedure has been phenomenal in the last 4 or 5 years. I'll come to that in a minute. And there are special techniques available, which are endovascular and epicardial, called the Lariat device, which is also implanted percutaneously with a pericardial approach. This is just a short video showing the implant technique. All implantations are done using the femoral vein. We do a transseptal puncture. Once transseptal puncture is done, we measure the size of the left atrial appendage using intracardiac echo. The size of the device is then tailored to the patient's need. The appendage shapes are very variable. They're like fingerprints. Some patients have the commonly known shapes of broccoli or chicken wing or windsock. An angiogram is done, and that helps in further confirming the size that has been done by intracardiac echo. Once an angio is done, the pigtail catheter is removed. We introduce the device and unsheath it, which leads to positioning the device. The stability is confirmed by pulling on it. We do an angiogram and make sure there's no leak around the device. Usually the implant time is between half an hour to 45 minutes, at the most 1 hour. If one size doesn't fit well, we remove it and try a second size. The success rate of these procedures has dramatically improved. This is a picture showing the position of the device, occluding the left atrial appendage totally. This is the endothelialization of the device in a patient who died 9 months from an unrelated cause, showing how left atrial appendage is totally occluded, and all you see is the central button here. And this is the angiographic view of the device. I think it can be seen, though, with some difficulty. So this is now daily practice. What do we do? What's the data available? I think the first trial looking at the use of this device was comparison with warfarin, which was the main anticoagulation being used about 12 to 15 years back. And the PROTECT AFib trial randomized patients into warfarin versus a Watchman device. And this showed that Watchman was a reasonable alternative to warfarin in patients with non-valvular atrial fibrillation. at risk of stroke. We do measure the risk by seeing the CHA2DS2-VASc score, and a CHA2DS2-VASc score of more than 2 to 3 was advised to be included in the trial. There was an upfront increase in safety events, mainly pericardial tamponade, which was sheath-related. There was a small incidence of device embolization, and there was a clear learning curve. The incidence of these complications over the next 10 years has really dramatically come down. And I'll go into the indications in a minute. But remember, the first trial that was done was comparing these devices with warfarin, which is not the clinical practice these days. This slide is something what Sumit, to some extent, did elaborate. The incidence of post-procedure bleeding with these devices is significantly down. And this is data from a larger study showing freedom from bleeding over the follow-up period was 72% lower in patients who got a device as compared to control population. So that's the main advantage of these devices. This slide, again, showing the incidence of stroke. Well, this is the expected incidence of stroke based on the CHA2DS2-VASc score in the evolution trial. And use of anticoagulation and implantable devices reduced the incidence of stroke from 6.4 to 1.1%. And the second part of this trace of the slide shows the incidence of expected bleeding based on the Hasbled score, the score that we use to quantify the risk of bleeding in patients with atrial fibrillation. And the Hasbled score showed that the expected bleeding incidence in these patients came down from 4.7% to 1.7%. So everything really showed that putting a device in and the patient's on was better than warfarin. The current indications, however, FDA took a very conservative approach, and when they approved the device based on the data, it said that percutaneous left atrial occlusion may be considered in patients with atrial fibrillation with increased risk of stroke who have contraindication to long-term anticoagulation. So it did not really immediately approve for all patients. And this was not based initially on any concrete data, but mainly to keep some range on the number of devices we implant. I would also like to just add that the role of left atrial appendage closure also has been investigated in the surgical field, and more trials are coming out, the most important being the Laos trial from Canada, showing that surgical occlusion of the left atrial appendage also leads to a significant reduction in long-term mortality with low bleeding risk. At the moment, where do we stand? Well, we are now, as far as clinicians are concerned, indications have really been extended substantially. I, in my practice, have started doing left atrial appendage occlusion devices from more than what the FDA had initially summarized. These 5 groups form a substantial part of the patients who are undergoing left atrial appendage. First group is patients where there's total contraindication to use of anticoagulation. And an example would be a patient who's had a subdural hemorrhage or intracranial hemorrhage where you would not really consider using anticoagulation as the risk is so high. The second group is patients who are bleeders. They have previous bleeds, major GI bleed. They have not even tried oral anticoagulation because of risk of bleeding. So we now upfront have been starting doing devices in these patients and obviously also concomitant procedures. Future bleeders, patients who have coronary artery disease, have had multiple stents. They are on aspirin and Plavix. And then you would be adding a third anticoagulation. You are going to increase the risk of bleeding substantially in these patients. So that's another group which is being targeted for use of devices upfront. Non-compliance, especially poor patients, personality, they don't want to take anticoagulation, risk of, so that's another group. And finally, lifestyles. And the large group are patients whose entertainment in life is on professions or say motorcycle riders. They don't want to take anticoagulations at all. People who go skiing regularly, they're scared of having a head injury and having an intracranial bleed. So we have really stretched the envelope based on our experience. Patients who have fall risks, patients with chronic renal failure, and these are going to be extended, and I'm sure you will see more and more patients who choose upfront to have a device as compared to oral anticoagulation. The biggest change has been recent trials that are comparing the use of left atrial appendage closure as compared to NOACs. And this is the real world data, because we don't use warfarin, which was used for initial trials. The first of these trials was the Prague 17 trial, where 412 patients who had high-risk atrial fibrillation were randomized to use oral anticoagulation versus left atrial appendage closure. And on long-term follow-up, over 30 months average, the left atrial appendage closure was non-inferior to oral anticoagulation, and all parameters, including the primary endpoints and the secondary endpoints, was similar in the two groups. So this is the first set of data showing the advantage of these devices. At least they attain the same result as compared to anticoagulation. Going further, the Champion AFib trial, which is different from the Champion heart failure trial, randomized 3,000 patients at 150 sites. It's 1-to-1 randomization between Watchman Flex and NOACs with a 5-year follow-up. And Watchman Flex is non-inferior for the occurrence of stroke, including ischemic stroke and hemorrhagic stroke, cardiovascular death, including unexplained death, and systemic embolization at 36 months. Watchman Flex was also superior to non-procedure bleeding in terms of intracranial bleeding and clinically relevant major or minor bleeding. It was non-inferior for the occurrence of ischemic strokes and systemic embolization at 60 months. The second device that has been now approved by FDA and forms at least 20 to 30% of left atrial appendage occlusion is the Amulet device, which is made by Abbott. This device is different from the Watchman device, which has two levels of occlusion. It has a lobe and a plate in front of that. Again, a Catalyst trial looked at the same data, Amulet versus NOACs, showing it was a non-inferior to oral anticoagulation, both in its primary outcomes and secondary outcomes. I'm not going to go into the details. This is the last part of the presentation, which is the comparison of two devices that are now commercially available in the United States. This is the Swiss APRO study, where patients were randomized into either a Watchman or an Amulet device. Choice is to some extent personal, but in this trial, they randomized 111 patients into Amulet and 85 into Watchman Flex. The primary endpoints in terms of cardiovascular death, stroke, and major bleeding was similar in the two groups. The only difference was that the peri-device leak was lower in patients with Amulet, probably related to a double disc as compared to the Watchman device, 13.7% versus 27.5%. The risk of pericardial bleed was slightly higher with the Amulet device related to the design of the device, 9% versus 2.7%. Obviously, people doing large volume of devices often choose the device dependent on the shape of the appendage and their comfort level. So where do we stand? Well, we are always scared about complications, and you really want safety is a very important part of what we do in terms of ablation or devices. The major complication with left atrial appendage, in fact, the left atrial appendage is a very thin structure, and these devices have very small tines that hold the device in position. So the biggest problem was the incidence of pericardial effusion. requiring either pericardiocentesis or surgical if it's a large bleed. The incidence of these bleeds have indeed come down with experience and second version of these devices, and it's not more than 1 to 2% in the current design. Procedure-related strokes, again, incidence is very low, and device embolization indeed has also. But we are seeing another new set of problems that we see with the devices. One is device-related thrombosis. Despite using anticoagulation, about 2 to 3% of these patients develop a clot on the device. And this video shows, it's one of my patients from 3 weeks back. She came for a follow-up. This is a Watchman device, and you can see this clot flapping on the device despite using aspirin and Plavix. The second big problem is that some of the devices do move a little bit and they develop a leak on follow-up, and device leak closure is an expanding field. There's another patient of ours who had a device and came back with a small leak. The contrast injection shows a leak at the back of the device, and we had to close the leak and then hopefully expect that it will stay as it is. So the incidence of complications is coming down over years. The field is expanding, and this is actually a slide provided by one of the researchers showing the extent to which the device volume has grown and the expected growth in this field over the next 5 years, from 20 to 30 in terms of revenue from these devices. So with this, I'm going to stop and take questions. Thank you very much for the invitation.
Thank you, Davinder. I'm getting some questions. I should be on the video. I know your video is not working.
That's okay, but I can hear you clearly.
Okay. So I think the message of, both the talks indeed is the main topic. Can we be without drugs? I think we've made significant strides in an electrical disease, which many times is a consequence of disease, heart failure, cardiomyopathy, coronary artery disease, ischemia, and of course, aging. So, to get to this point that you can think about curing atrial fibrillation, and you can think of stopping anticoagulation in such a disease entity shows that we made significant progress in this field. In the late 90s, I was a skeptic about ablation, and many of us were, but I think we've made rapid strides in this area based on all the data you've shown and our own experiences. Again, to you, Dr. Mehta, one is, and you mentioned in the DRT, right, the right-radius thrombus. So, the question is based on a meta-analysis we've done, is that the risk of residual strokes, ischemic strokes, may not all be sort of emboli related, right? The commonest reason is actually a DRT. So what is your practice, and indeed the practice of Suneet, about stopping anticoagulation and using dual antiplatelets, though the FDA allows it? How do you decide? Do you stop anticoagulation after successful closure in all patients, or do you keep some of them on anticoagulation until 6 weeks, until you ensure that there is no DRT and there's no sort of leak and there's sort of satisfactory occlusion? So first to you, Dr. Med. How do you choose, or do you just stop it on all and just put them on dual antiplatelets?
I think each patient is very individual. If you have a patient with paroxysmal AFib, the CHA2DS2-VASc score is 1 to 2, and you're not doing an ablation at the same time, I do stop. I just put them on aspirin Plavix straight away and do repeat TEE at 6 weeks. On the other hand, high-risk patients with a CHA2DS score, which is significantly high, being 4 or 5, or you're doing a concomitant ablation, which is an important thing now. Those patients do continue anticoagulation at least for 6 weeks till they have a TEE, and then decide accordingly. I must say that DRT is a problem more for on TEEs. It's not a big problem in terms of, I've not seen many strokes related to DRT. And this patient I just showed you the video is a good example. She had that clot, and I said, well, we arranged to really remove the clot by aspirating it. And I arranged everything, and we thought we'll take the clot out, which I've done once before. And to our utter surprise, she comes after a week for the procedure, and the clot is gone.
Yeah.
So it is more of an echo problem. There's a very small incidence of DRT leading to strokes. And I presume those patients, you have to continue anticoagulation till the clot is totally gone.
Great. You, Suneet, what are your thoughts on this?
So Atul, again, you raise a number of important questions that, again, if you ask a all bunch of people, you're going to get all different answers. And whenever that happens, it's because we don't know. But again, I'm going to punt by saying we will soon know, because there's a very important trial currently underway called the Simplify trial that people should be aware of. The Simplify trial takes patients who have, and let's exclude the ones who've been ablated, just the people who've undergone Watchman, and they're being randomized into one of 3 arms right from the time of implant. They either get aspirin alone, they get dual antiplatelet therapy with aspirin and clopidogrel, or they get apixaban 2.5 milligrams twice daily. Everyone will get a TE at 6 weeks. That will help us determine whether there's a difference in DRT between these 3 arms. And then, of course, at 3 months, the people in the low-dose apixaban arm will be transitioned to aspirin alone. And those in the DAPT arm at 6 months will get transitioned to aspirin alone, and they'll be followed to see if there's any difference in stroke rate between the 3 arms. So it will finally help us answer these questions that you're raising. Is there a difference in DRT rate related to different regimens? And what is the lowest regimen you can go to that can safely avoid the need for ongoing anticoagulation? As Dave mentioned, remember, we started where you needed full dose warfarin and aspirin immediately after this procedure, and have quickly realized that not so much is needed, but how little is needed, we need studies to help us know.
Thank you. And as both of you mentioned, it seems that the most important factor is indeed the CHA2DS score for many of our decisions, which really reflects the disease status of an individual who has atrial fibrillation. It adds in all the comorbidities of atrial fibrillation, and emphasizes that fact, whether it's outcomes of stroke, whether outcomes of atrial fibrillation, outcomes of stroke, anticoagulation. And the CHA2DS score seems to be at the center of all. While you were both talking, I had some questions. If those who ask questions could say, I just have a question.
This is from Hetal Gore.
Yeah, I've had a question that, how do I know if I have atrial fibrillation, if I've had an eye problem? Is that the question? That was one question. The other question, which I do remember, is sort of pregnancy related. How do you deal with implantation of a Watchman or ablation when you are pregnant, or when you are intending to be pregnant? On a humorous note, if I may add, atrial fibrillation is still a disease of people with white hair. And at the moment, we're only getting pregnant up till the age of 40, 42, or rarely 48. So I don't think that sort of situation arises that often. But over to both of you. I mean, how do you handle it with the right intention to become sort of pregnant? But I guess anticoagulation.
I mean, I understand the question, but it really is not a major clinical issue. Like I really don't remember the last time I had to deal with pregnancy and AFib in the same patient. Obviously, we deal with pregnancy and the need for anticoagulation for other things. They may have a valve or some other thing that's happened, but I wouldn't say that that's a major issue. With respect to the other issue you raised with the eye issue, if you've had an unexplained stroke of any kind or a thromboembolic event, then most people would implant a loop recorder for long-term ECG monitoring to look beyond the 1, 2, or 4 weeks that's possible with an ambulatory external ECG monitor.
So and to answer a question that if you have it sort of TIA, or what we still call a sort of cryptogenic stroke, unexplained without all the other conventional risk factors of atherosclerosis, then yes, either external monitoring or implantation of a loop monitor to look for atrial fibrillation. And if I remember correctly, there was a flurry of trials on cryptogenic stroke about 4 years ago, and the incidence of asymptomatic atrial fibrillation was in the order of about 33%. That means all comers, but again, based on the CHA2DS2-VASc score also. So unexplained embolic phenomena, look for atrial fibrillation either with an external monitor or an implantable loop monitor, which was really sort of going great guns about 4 years ago in all our meetings we went to. So that has been that question. Are there any other questions?
I think Dr. Neravatla has a comment.
Thank you, Tarak. Thank you for giving me this opportunity. I enjoyed this presentation very much. I'm a cardiac surgeon, and I deal with this problem in a slightly different way than what you guys do, but we work in coordination with cardiologists all the time, dealing with this problem in surgery. One comment is that atrial fibrillation is not merely the problem of our patients. It's a problem of the membership of AAPI. I'm talking about physicians who are members of AAPI who have atrial fibrillation and their family members, and so on and so forth. So I was hoping there'll be more robust participation in this talk because it's a very, very important topic. Having said that, Dr. Prakash has mentioned this is a problem of age. I'd like to offer a slight variation on that description. It's not merely chronological age, but the age, duration of how long you've had some of the risk factors for atrial fibrillation, most notably hypertension. More recently, one of my classmates, family member who's only 45-year-old, had a stroke while he was walking in New Jersey. And turns out he had what we now call type 2 hypertension, very severe hypertension, which he was not aware of. So this is a hypertension to atrial fibrillation, hypertension-related scarring of the heart that eventually leads to atrial fibrillation should be considered a major preventable cause, along with factors like sleep apnea, which are definitely controllable from that point of view. One other comment, if I may, is you mentioned quite a few times about stroke risk with atrial fibrillation. In fact, 75% of the people with stroke have hypertension and or atrial fibrillation, very high number. Having said that, one more point is dementia is a problem that we are dealing with in our older generation, our own families. It's affecting a lot of us. And having atrial fibrillation causing cryptogenic strokes, as Dr. Prakash just mentioned, is a very subtle and important factor in dementia, which is something that is growing rapidly in all populations, especially in Indians at much younger age, unfortunately, like everything cardiovascular. Other than that, I very much enjoyed the presentation, very professional, very up-to-date, state-of-the-art management technology available in atrial fibrillation. But I hope, like everything else in medicine, just because you have new tools and new technology, we don't forget prevention. All the more we should pay attention to prevention. Thank you, Tarak, for giving me this opportunity.
Thank you.
Thank you for your comments, and just to and you know, everything you said is absolutely spot on. When I said age, it is not the number. I mean, you know, aging starts at the age of 1, thereafter. And the degree of aging all depends on, that's why I mentioned the Chadwell score. It is all the comorbidities which increase your age. If you're hypertensive, diabetic, heart failure, it all increases your stroke risk or atrial fibrillation risk. So yes, and this is one part of technology, but the cornerstone of atrial fibrillation health is the same as health of all of our diseases, and indeed aging. It is the same rules: diet, exercise, diabetes, hypertension. And that starts not from the age of about 40, it starts at the age of 18. So all these things should be implemented. But yes, absolutely right. I don't want to stray away from this. But here, I mean, the objective was that certainly a disease in the late 90s where there were trials which said, ah, well, you can leave someone in atrial fibrillation. It doesn't affect the mortality. We know most of our admissions on the floors are because of heart failure with actually preserved ejection fraction. If you go to any floor, anyone over the age of 70, 80 is admitted with heart failure as soon as they've gone in atrial fibrillation. So it impacts the quality of life, and you go down a spiral. So I think man was meant to be in normal sinus rhythm, and as per what Sunit did and what we all do, if we implement it early, we can take away atrial fibrillation, and if we don't, we can at least stop anticoagulation. So I think that was the message we wanted to bring out, and I don't know if are there any more questions?
Thank you,
How much
Tarak.
it costs,
Thank you,
these
Doctor.
procedures? Do they cost a lot for the patient? Of course, most of them are on Medicare, likely.
I mean, the cost does come into play, and somewhat, Sunit and Devendra there, the cost of doing concomitant procedures is there. That's why I brought that point up. But here we're not going after the cost. We're saying what does sort of data say with outcome and efficacy.
Mhm.
Of course, you know that only in America is it possible procedures can cost less than antiarrhythmic drugs and/or oral
Yes.
anticoagulation. So our system is really messed up, as you all well know. And the fact that people come asking for Watchman to save on the cost of Eliquis is in itself a mind-blowing proposition.
Yeah.
Very well said. And the
Yeah.
cost of Eliquis or the anticoagulants
That's true.
ranges from about $500 to $800 a month for a Medicare recipient with a secondary. I don't want to get into the economics of it, but they would rather have a Watchman in and not pay that amount every month.
There are a couple of questions, Dr. Prakash.
Sure.
Can I read it? Yeah.
Yes, please.
Please.
Or text them to me. Maybe I'm looking at you. I'm not looking
Yeah,
at
that's okay. I'm just reading it, and you can take it from
Sure.
there. There is a question from Dr. Nawani. Just curious, PDA uncovered during these procedures, PDA causing a AFib and stroke incidence management. Question is, what are the incidents and what's the management?
I'm not understanding PDA. I mean, to me,
I have
PDA is
no
a
idea.
patent ductus arteriosus. I mean, maybe, I'm missing something here.
Yeah, I think that may be the question, but I don't know. I'm not a cardiologist.
So I think, we all would not be competent to answer the question.
Dr. Nawani, you can unmute yourself and ask the question if you are here.
Yes, please.
And there is a question from Dr. Jaykishan, is after Watchman device implantation, Here you go. 3 to 5 mm device leak. Is that okay?
Dr. Mehta and Dr. Mittal.
Yeah.
No leak
So
is okay. No leak is okay. We're
I think
trying
it's
to,
okay. Yes.
yeah, no, we're trying to figure out ways to ensure that leaking doesn't occur. Certainly anything over 3 millimeters is really a problem. But I think most people, the goal of the procedure is to have zero leak. Now, part of the problem is that leak has another level of complexity, which is there's TE detected leak, which is what most of the data is from, but it's not as sensitive as CT, and a lot of us get CT, and CT really humbles you because what looks to be a perfect closure on TE, even there you'll find very small leaks, and we're struggling to determine, what to do with it. So it's still a field that has a lot of unanswered questions.
There is one more question here.
Dr. Mehta,
Go
I
ahead.
have a great question after Dr. Mehta gives a comment on this.
Okay.
The-
can you hear
on
me?
the leak. Yeah, on the leak issue.
I think it's a leak issue is a moving target, So I've seen in seeing people around me in practice, I have really not closed any leaks smaller than 2 to 3 millimeters. In fact, most of the leaks I have closed are the patients who've had an event with a leak. They've had a small stroke, or so there I definitely close. Small leaks up 1 to 2 millimeters, really, first of all, they're difficult to close. Secondly, there's no indication to close them as far as the current data is concerned.
Dr. Vasudeva, this is Dr. Navani. I was able to unmute. Let me know when I can ask my question, please.
Yeah, just hang around, and then when the discussion is over, you are there. So just ask the question.
Okay.
If you feel like jumping in, Dr. Nawan.
Okay.
Go ahead. I think that was my comment about the leaks. So leaks more than 3 to 4 millimeters, or those associated with an event, should be closed. Yeah.
Okay, but if there is no event, the person says they had a CT angiography detected leak. Dr. Jaikishan added that comment. But got it.
Yeah, so if the CT angio does show a leak, which is say more than 3 to 4 millimeters, obviously I would like to close it to prevent any future events in those patients. Yeah, but less than 2 at the moment, I am not doing anything. And I think the data about those leaks is also not very convincing that they should be closed.
Go ahead, Dr. Nawani.
Okay, this is a non-cardiologist question. So in event there is a patent ductus arteriosus causing AFib and stroke, is there any data for any of these devices being helpful, or is there just nothing to do with any of these things? Do these procedures help in those cases? And is there anything where these can be done concomitantly, the left atrial appendage closure, and is that going to help in that event? Or just closing the PDA will help?
Is it possible you're thinking of PFO in stroke, patent foramen ovale? Because
Yes,
yeah.
PFO.
Yeah. No, I don't think that in that substrate, one would be thinking of left atrial appendage closure. Of course, there's a lot of data, and a lot of debate about antiplatelet versus anticoagulant versus closure of a PFO to prevent further stroke. And, I think that it depends on who you ask, and the size and all of those things matter. But in those patients, because the problem is they have no known history of atrial fibrillation, we're not thinking about left atrial appendage closure because the
Okay.
stroke mechanism is different.
And I might just add that all the data that Suneet and I presented refers to non-valvular atrial fibrillation. So
Okay.
those small groups, we really don't have any data, obviously, PFO closures and all. And there's a big debate about mitral valve disease and stroke. And so there's no doubt we presume two things, that AFib strokes are caused by a clot in the left atrial appendage. That's the big presumption behind all this, which is a full different debate. But the current data all is in reference to non-valvular atrial fibrillation.
Thank you.
In the interest of time, there's an excellent question on external ligation of the appendage by by a surgeon. While I'm waiting, I mean, it was and still is the practice to close the appendage if someone is undergoing open heart surgery, but to ensure that the closure is adequate. Your thoughts, Dr. Mehta, Dr. Mittal, last surgical excision of the appendage during open heart surgery.
So
So
we
go
know
ahead,
from
sorry.
randomized
Go ahead,
studies.
Sunit.
Yeah. No, I'm sorry, Dave. Go ahead.
So there are multiple techniques, multiple surgical techniques that are used to close appendages. Overswing the appendage, atrial clip, and most of them are indeed fairly effective. The indications are now getting more and more well defined, and any patient who's having surgery and has a high CHA2DS2-VASc score, unrelated surgery, bypass surgery, or a valve replacement, it is advisable that we close the appendage. Um, in my practice, again, I have seen patients who had an appendage closure or a clip put in and then came in with a stroke, and we found there was a leak. And so the success rate of surgical closure is very high, but there is a significant failure rate in these patients. So we are not recommending routine TEEs after surgery, but it's something that has to be kept in mind in clinical practice.
Thank you. I think Dr. Mittal has to go, so I want to thank him specially for taking the time on this evening. Sunit, thank you. Thank you very much. Dr. Mehta and I are still here. If there are any burning questions, or we're waiting for...
I think I'm hoping for Amit to come back.
Yes, I'm here.
Okay.
I'm here. Are we done of the Atul also has spoken and stuff?
Yeah.
Amit has spoken. If you give me a minute, I'd love to add a sort of philosophical slant to atrial fibrillation.
Yeah, absolutely. And then I'll add a philosophical slang to the whole talk.
Okay, so this is of all the things I have published, I rank this highly. So, atrial fibrillation is like all disease. It grows and sort of self-perpetuates. I mean, the more you have, the more you will get. So you have got to break it. But an atrial fibrillation occurs because of risk factors. What are the risk factors? So risk factors are high blood pressure, diabetes, heart disease, and so on and so forth. Human behavior amongst all of us is sort of very similar. How we first interact with a person is based on our impression of the person. So the answer to this is within all your own minds, you know it. And thereafter, our interactions with the same person either go on a negative spiral or a positive spiral. So the addendum here is disease we cannot treat or regulate, and we cannot interfere with this escalation of disease because it is based on organic aging. But our minds, we can certainly stop at each sense of time as sort of time goes on. So that's the similarity. It is said that AFib begets AFib. So that's why if we treat early ablation, we can be sort of devoid of drugs. That's my little spiel. Over to you, Amit.
Thank you so much. Hey, Atul, great panel, great speech, great talk. Me being not even a cardiologist, and a lot of other people are not cardiologists. We learned a lot from from the talk and the interactions. And what I can take away from this, that the original slang or original thing is that the best way to a man's heart is through the stomach. I think the best way to a man's heart through the femoral vein. So I learned that today. And so I think we should keep this thing on. And please, next time also, we'd like to have more participation, get this message out. I'll ask Tarak to actually have the panel completely set, and he's working on it by the beginning of the month. beginning of September, we'll have the next panel already set. And so we'll start advertising and putting the thing on from first week of September. And actually for everybody, it's going to be the third Sunday of September, and it'll be the third Sunday of every month, unless we have got a conflict. And next topic is AI. We've got excellent speakers, and this is going to be a topic for everybody, every specialty, because we are going to talk about AI, and how AI can facilitate your practice. And more importantly, we've got another great speaker, which I just recently identified, who will speak on medical legal aspects of AI, using AI in your practice. We use AI indiscriminately, but there are some legal aspects of AI, using AI, and that's somebody who is absolutely an author, a speaker, and she's an authority on that. And I'm trying to get her to also speak. She's one of our AAPI members, and I just happened to just come across what she does, and it'll be a great event next time. Also, like every other events we have had this year, this will be of interest to every doctor, irrespective of what specialty you are. So please keep your calendars open for the third Sunday of September for this exciting talk, which is Suresh Reddy, Tarak Vasavada. They're going to try to put this together. I'm very excited, and thank you very much for doing this, Tarak, and thank you everybody for attending. And please watch out for the email, where you just need to fill out a few questions, and you get the CME directly in your email. The most easy way of getting CMEs ever. Thank you for EMED events for doing this and making this very seamless. And over to you, Tarak.
No, I just want to say thank you for everybody who spent their valuable evening time. And please come back on September 21st, like we said, and we'll see you.
Thank you, Tarak. Thank you.
Thank you, everyone.
Thank
Great
you,
to be
Dr.
there.
Mehta.
Bye.